My name is Erin Mahoney, and I welcome you to our workshop titled Transplantation Beyond the Lungs, How and Where We Begin.
Oh.
My name is Erin Mahoney. I'm a nurse practitioner from Loyola University Medical Center in Chicago, and my co-moderator is Bob Toner. He will be operating the Slido for our questions and answers. The session description is to transition from CF center to transplant center can be a difficult step for the CF patient and their family. We will explore timelines of the referral process, communication techniques, and best practices in the CF lung and liver transplant transition. Our objectives for this workshop is to identify who to refer and when to refer to the transplant center, to discuss how to keep good communication between the CF center, transplant center, and the CF patient, and to examine best practices for outcomes and discuss the use of Trikafta and Cftr modulators in the setting of transplant. I welcome our panel of presenters. I hope that we have a really robust Q&A. Our first presenter is going to be Katie Henthorn, who will be talking about education and virtual support groups. We'll be following that up with Dr. Ramos, who will be talking about CF stories as a form of education in the pre-transplant period. We will be following that up with Dr. Midar Oxler, talking about pediatric palliative care, which I think is a very interesting topic to talk about. That will be followed by Yenny from, I believe, from California, talking about a standardization of lung transplant discussion. And then Dr. Sellers will be rounding it out, talking about the impact of Cftr modulators on pediatric liver health. Just some housekeeping, please submit any questions to the presenters on Slido using the top right portion of your screen. We will be having about 8 minutes after each presentation to go through questions, and each presenter can also be reached directly either via email or the chat function on the conference website. So with the housekeeping out of the way, let's go ahead and start with our first presenter. We have Katie Henthorn. She is a licensed clinical social worker at the Adult Cystic Fibrosis Center, Long Island Jewish Medical Center of Northwell Health, New York. She graduated, She graduated with her master's in social work from Stony Brook University School of Social Welfare in 2014. Katie has been working with patients with cystic fibrosis in the role of social worker for over 5 years. In 2019, she took on the additional role of mental health coordinator and has been providing therapy services for cystic fibrosis patients struggling with mental health complications. Katie is an active participant in the Quality Improvement Initiative and is particularly invested in lung transplantation and palliative care initiatives. Katie also works collaboratively with her research counterparts to provide opportunities for her patients and to further qualitative research for individuals with CF. She moderates the CF Center's virtual support group program and enjoys connecting with her patients. Katie is an integral member of her CF team and is valued by her patients and colleagues.
Hello, my name is Kathleen Henthorn, and I am a licensed clinical social worker at the Northwell Health Long Island Jewish Medical Center Adult CF Program. I am presenting today access to education and support to adults with cystic fibrosis by virtual support group with a focus on readiness for lung transplant. I have no relationships to disclose related to this presentation. At the Northwell Health Long Island Jewish Medical Center Adult CF Program, we have 87 patients according to our 2020 CFF Patient Registry Report. I have included some demographics here. Most importantly, our rates of anxiety being 28% and depression rates of 17%. We had 9 patients diagnosed with COVID-19 in 2020. As well, we have 18% of our patients with advanced lung disease, which is drastically higher than that of the national average of 5.3%. Our LIJMC adult CF team consists of myself, who functions in the role of social worker and mental health coordinator, 2 registered dietitians, 2 advanced care practitioners, a nurse practitioner and a physician assistant, 2 respiratory therapists, 2 physicians, and 1 research assistant. In 2019, we began our partnership with Columbia University Medical Center to focus on improving the process of lung transplant transition. Individually and collectively, we focused on improving access to and coordination with advanced care planning, palliative care, and transplant transition and education. The first photo is from our in-person training together, and the following picture is a team Zoom picture from one of our weekly meetings. And so it began. Our center became interested in conducting an educational support group when we initiated a quality improvement program relating to lung transplantation needs in our CF patients. We partnered with Columbia University Medical Center's lung transplant team, and together we brainstormed how to increase education and support to our patients. This led to our model of a support group that combined learning sessions with guest speakers and created an open forum for patients to ask questions, share experiences, and be supported in conversations. I've included here our support group flyer that we provided virtually and in person to our patients. As well, displayed as the cover of our support group playbook that outlined the documents utilized for this program. As an overview, I've included our Pdsa cycle that outlined the process of our group. In March of 2020, we plan to coordinate a 10-session virtual support group program that included 4 educational topics, with 2 being related to lung transplant, as well as 6 open forum discussion sessions. From May to September of 2020, we completed the support group program, inviting the Columbia Transplant team as guest speakers. We surveyed the patients in relation to knowledge gained and supportive scale throughout the program, and at its conclusion. This is now a standard of care practice, and we plan to provide these groups to our patients annually. So our center is not a stranger to support groups. Personally, this is something that I enjoy providing to our patients, since it allows for an opportunity to share experiences and feel heard and understood. A few years ago, our center performed a similar pilot program where we utilized the same format of an educational virtual support group. I was responsible for recruitment of interested patients from our center, where I created the flyer that you saw previously and distributed to patients both by email, in person, as well as in discussion with individual patients. I then was responsible for tracking interested patients and clarifying their availability for when the group would take place. Once patients were identified, I offered and participated in trialing the virtual platform with them prior to the start of the group. This helped to mediate potential technical difficulties with the participants and eliminate excess time taken for these issues at the beginning of the sessions. As well, patients were responsible for completing consents to participate via REDCap. The surveys the patients were required to complete were the demographics questionnaire, needs assessment, PHQ-9, GAD-7, UCLA loneliness scale, and COVID-19 impact scale. For every educational session, each participant was asked to complete a pre-survey and a post-survey in relation to the session. I also forwarded each virtual session link via Microsoft Teams bi-weekly to the participants and speakers. In regards to coordinating our guest speakers, I reached out to the CUMC lung transplant providers to see if they were willing and able to present to our patients. I also discussed availability between team members, including our physician, registered dietitians, respiratory therapists, and myself when available to present. Once identified, speakers were responsible for developing PowerPoints related to their education topic and pre-post tests. Once completed, I reviewed each presentation and provided feedback if needed. I moderated 10 sessions in total, consisting of 6 open forum and 4 education-based topics, including nutrition, mental health, and pre-post transplant. In total, I had 9 patients participate from May to October of 2020. The sessions were 60 minutes long. Educational sessions were made up of 30-minute presentations and 30-minute Q&A discussion. Due to positive feedback from the group, we plan to repeat in 1 year. In total, we had 9 patient participants. Once identified, the patients were asked to complete a demographics questionnaire, needs assessment, PHQ-9, GAD-7, UCLA loneliness scale, and COVID-19 impact scale. Our demographics result highlighted difference from that of our general population, including with marital status. More individuals were married in our group in comparison to our center's demographics. As well, our racial background of our patients included in the support group is reflective of that of our patient population, with majority Caucasian and 11% Hispanic. Many of our patients included in the support group were unable to work due to their health. Our baseline assessments demonstrated a need for support, education, and social interaction, especially as the COVID-19 pandemic was immensely impacting individuals with CF. This placed people with CF, a group already at risk of social isolation, at further risk. For our pre-transplant educational session, our CF physician, Dr. Janice Wong, presented. She discussed why lung transplant is an option for individuals with cystic fibrosis, especially why it is important to discuss transplant early on in a person's CF journey. The benefits of discussing it early include early referral increases the chances of a patient becoming a transplant candidate, as there is time to address potential barriers and increase knowledge and preparedness. Dr. Wong also discussed the testing that is required for transplant evaluation. She discussed the very misunderstood concept of consultation, evaluation, referral, and listing. This is a big topic and allowed for great discussion between our patients and speakers. Dr. Wong spoke about how discussion regarding lung transplant is recommended when a person's FEV1 is at 50% predicted. I really like the slide that Dr. Wong used here that highlighted the journey through lung transplant from discussing transplant all the way through receiving new lungs. Dr. Salim Arkasoy and Hae-Young Kim presented for our post-transplant educational session as our guest speakers from CUMC. They initiated their presentation by discussing what to expect once you are placed on the waiting list, including the very controversial topic of dry runs. Dr. Arkasoy spoke about how people listed for transplant how long they have to wait and how it is often unpredictable, as well as a day in the life post-transplant as it pertains to the importance of close follow-up and monitoring, medication compliance, lifestyle, and diet changes. We had a great mix of patients included in these sessions, including patients post-transplant, individuals following with transplant, and those that have never discussed transplant before with a healthcare provider. This allowed for great conversation and questions for our speakers. I present here the pre-post test for our transplant sessions. The participants showed a moderate improvement in knowledge scores following both of these sessions. Shown is our satisfaction survey with an average score of 68.11 out of a max score of 80. Also shown is our support group outcomes table. We saw a mild decrease in both anxiety and depression symptoms from our participants. In contrast, we did see an increase in our patients' loneliness scores. We did consider that at this point, the COVID-19 pandemic had continued to restrict social interaction at the time of the post-assessment, which could explain the increase in these scores for our participants. The most impactful benefit of the support group, in my opinion, is seen in the participant quotes. Participants found the support group to be a helpful and positive experience, stating, for example, "You were the first people I've ever met who had CF. Lung transplant acceptance isn't easy, but I mean, when you're sick, what are your alternatives? What is the best way to live?" It allowed for a safe space for participants to relate and provide advice regarding having an invisible disease. As an older person with CF, and I always looked healthy, if only I feel as good as I look. Participants felt a sense of community. I'm happy to talk to you guys, and when I speak with our community, it's great. Participants discussed how they initially learned of transplant for people with CF and the importance of needing a platform to discuss it with their medical providers. No, I had this conversation when I was at pediatrics, just because I watched an episode of Grey's Anatomy and it came up. I had never thought about it before, but then you see it and I'm starting to think about it. So I'm always kind of keeping myself in the know, just in case, who knows down the line, if I do need it, it's not too overwhelming because I have the information already. Participants discussed the education regarding transplant and regarded, I think it's good to know in advance before you have to think about it seriously. Thank you all so much for listening, and a special thank you to my LIJMC CF and research team, the CUMC transplant team, and our coaches Randy Messier and Jamie Carey.
That was really, really interesting. Thank you so much for sharing that. I think that some of the things that I hear when people are trying to start a support group is just the overwhelming process of where do you begin? So if you could offer, where does a person begin? I think you outlined a lot of steps, but sometimes just getting over the hump is the hardest part.
So initially when COVID happened, we were trying to get it off the ground for a few weeks. I was doing a lot of individual sessions and really checking in individually with patients. And there was really a need for just a support group of some kind. So it was really, tapping into my resources at the CF team and with our research counterparts to say, all right, we want to get some data on this. How do we get this off the ground? And really using our team to the best of our ability. I knew that there was a need for it. I knew the patients wanted it. So it was really just taking the bull by the horn and doing it, really.
Great. And then there is a question from the audience. How did you engage patients to attend the education session for pre-transplant?
So the way that it was offered was as a 10-session group in total. So if patients were interested, they weren't committing to all 10 sessions, but the thought was that they would attend each of them. So it would really alternate between an open forum and an education session. So you had already kind of created that team and that group dynamic. So they wanted to attend the next group. I think that came with positives and negatives because the support group was offered to all participants of the center. But if they weren't already involved in the support group, they didn't necessarily just go to the transplant talk. So I think that was a positive and a negative for that. Like if it was offered as more of like a town hall, we may have gotten more participants for that one session, but we may have gotten less for the overall support group.
Okay. And then another question, this is from one of our co-speakers. For the people that attended the online support group, was this offered to all adults at your center? And if so, do you know how many were in the transplant referral window?
So it was offered to all of our patients at the center. So there was about 9 participants that attended the support groups. And I would say, so we had some that were post-transplant, and there was probably about 3 or 4 that needed to talk about transplant, but didn't want to talk about it. So it was really a great platform for them to put a face to the name of transplant and to actually be like, okay, they're not, it was kind of like the odds behind the curtain, and they were actually able to see them and ask questions and know that it wasn't that foreign. And having someone post-transplant actually on our sessions also gave that availability to ask questions and to actually hear from them how they're doing and how that process was like for them.
Okay. And then I really liked that you included the patient quotes, that you had it built into kind of your questions, and then also that you highlighted it here. I think that's really, really important to hear the patient's voice. And I thought it was very interesting that one of the first quotes was, I have never met someone with CF before, especially given how engaged our patients seem to be on Facebook and social media. What was your most surprising takeaway when you were reading those quotes?
So we have a decent amount of patients in our center that were diagnosed late in life. So I think that contributes to that. I don't know anyone else with CF. I've lived my life without knowing I had it, and I really haven't built that relationship with others with CF. So I think that was, and I had known that about that participant, so that wasn't as surprising. I think the Grey's Anatomy quote that I said was really, well, my patient had said, was really, I don't know, kind of sad for me that she lived her whole life with CF. And she's like, the first time I even thought it was an option for me was on a TV show. So I think that being able to, and she's very well, but being able to ask questions and say like, if I need this in the future, I know I'm not being sideswiped by a television show telling me what I may need.
Yeah. And then another question from the audience, how did you structure the open sessions? Was there a facilitator or was it open for the patients to lead?
So I facilitated each of the sessions. So both the educational sessions and the open forum sessions. And it just allowed for a little bit of structure. At least it gave, there's always people that are going to talk more, and it gave more of a structure for people that may not, to be able to have their voice heard and just kind of keep it balanced in that way. And I think that the participants and also the other speakers were receptive to me moderating and just helping with questions and flow.
Okay. And then one of the last questions is, where do you think that this project is going to go next?
So we definitely want to offer this type of program again. A 10-session support group is very time consuming. So that, as of right now may not be the most accessible thing to do, but maybe, in regards to just one session where we invite transplant speakers to talk and have patients ask questions, and maybe offer that on like an every other month basis for different topics, because there's definitely a need and a want from the patients to be educated on different topics, including transplant.
Great. I'm glad that you're going to keep it going. In the interest of time, we're going to go ahead and move on. And again, I thank Katie for sharing her journey with her developing this support group, and I encourage everyone to get out there and do it. So our next speaker is going to be Dr. Kathleen Ramos. A little bit about Kathleen. She completed her undergraduate degree in biology at the University of Pennsylvania. She went on to medical school at the Yale University School of Medicine, and her residency training occurred in primary care at Yale University, followed by an adult fellowship in pulmonary and critical care medicine at University of Washington. During her fellowship, Dr. Ramos was awarded the Safeway Outstanding Cystic Fibrosis Junior Clinical Research Award in 2015. Currently, she is a faculty member in the adult division of PCCM at the University of Washington. She is the co-PI for the University of Washington site in the CF Lung Transplant Consortium and is a member of the steering committee. Her clinical research interests include advanced CF-related lung disease, survival, and lung transplant. Her work has highlighted the need for an increased focus on the referral for lung transplant evaluation for patients with CF and advanced lung disease. She is currently leading a project to assess the effects of Cftr modulators in the post-lung transplant population, and is more broadly investigating approaches to improve post-transplant outcomes.
Hi, I'm Kathy Ramos, and I want to thank the workshop organizers for inviting me to share our work today. Here are my disclosures. Here's an outline for what we'll talk about today. First, an overview of lung transplant for CF, then a review of our qualitative analysis of CF lung transplant recipients' experiences, and then some preliminary data from CF stories. Lung transplant is a treatment option for advanced CF that has the potential to improve a patient's quality of life and extend an adult with CF's life by a decade or more. In the United States, once the FEV1 drops to below 30% of predicted, an equal number of patients die without transplant each year as undergo the procedure. And more than half of people who die without transplant weren't referred for transplant. Why is this? So timing the transplant window is difficult for patients and physicians alike. And now there's even more uncertainty in the timing of this decision, with highly effective modulator treatments available for a majority of patients. There's a lack of discussion of transplant in CF clinic, partially because clinic is very busy. There's a lot to talk about and a lot to cover in a visit, and transplant doesn't always seem like the most pressing topic until it is. There's also a lot of fear and stigma surrounding transplant, and so there's some avoidance. And then potentially modifiable barriers and treatable conditions may prevent referral and/or listing for transplant, things like non-adherence, psychiatric conditions, malnutrition. So how do people with CF prepare for lung transplant decisions? Well, we have data that shows CF patients with all levels of FEV1, including those treated with Trikafta, report an interest in understanding transplant as a potential treatment option. We decided to ask the experts, CF lung transplant recipients. We did interviews with CF lung transplant recipients who are age 18 years or older. And we interviewed them between April and June of 2020. They're all followed in the University of Washington lung transplant program. And we did purposive sampling to get equal participation by gender, balanced participation by location of their pre-transplant CF care. We prioritized those with a time since lung transplant less than 5 years. And we also took some recommendations from the transplant physicians to sample a variety of pre- and post-transplant conditions and complications. There were 86 people alive post-transplant at the University of Washington, and we approached 35. 12 people didn't return our calls, and we considered them non-responders, non-reachable. And 23 people actually consented to participate in the interviews. 2 people were lost to follow-up, and 1 person withdrew, and we ended up interviewing 20 people, which was a 57% participation rate. The interviews focused on decision-making about transplant and preferences for the pre-transplant communication with CF providers. Content analysis and extended analytic memoing were used to classify the data and locate themes within and across interviews. We established a structure for our memos. First, the individual's personal context, considerations related to the lung transplant decision, any informational needs that they had or they recommend addressing for people who are pre-transplant, and then additional observations. We established our initial content analysis framework as a group by reviewing the transcripts and the memos. The lung transplant recipients who participated in the interviews, their characteristics are shown here for the 20 people. They had an average age of 35 years old. They were 50% female, and their average time since transplant was about 3 years. 45% of them had received their pre-transplant CF care outside of the UW system, and their average FEV1 was 79% of predicted post-transplant, approximately 3 years out from transplant. 3 important themes arose from the interviews. Lung transplant as necessary versus a choice or decision. 2, the assurance that they gained from connecting with CF lung transplant recipients. And then 3, common areas of concern or information needs that were related to lung transplant. So thinking about choice, lung transplant as a choice, participants had mixed feelings on this. Many participants talked about seeing transplant as a necessity rather than an option, decision, or choice. And they felt that decision-making was sometimes rushed because of the severity of their lung disease. Interestingly, some of the people who felt rushed and felt like the timeline was really short had somewhere between 6 and 12 months between when they were referred and when they were transplanted, which in the transplant world is actually not that short of a timeline. Some people exhibited acceptance and even resignation about needing a lung transplant. One person said, "I think just finally knowing that this is the point, I'm choosing to do it, and getting everything started was kind of like, okay, we're doing this. It's happening. Let's do it." So the next theme, assurance from others. In conjunction with learning from the transplant team, people used online resources to access people with CF who were post-transplant. And many participants found information in the form of narratives. One person said, "I just wanted to know other people's experiences, both success stories and complications." Participants with a friend or a family member who had been through transplant also spoke about feeling more equipped to make their decision and weather the process, including the surgery and the recovery. And connections with others who had undergone lung transplant was most important for preparing for a majority of the transplant recipients. So the theme of common areas of concern, acting independently from their transplant team, patients who were pre-transplant, were seeking out information, and participants sought a centralized location for the information. And multiple participants described having to look all over the place to try to find the information about transplant that they were looking for. They also described preparing with and in relation to their loved ones, and they really emphasized the importance of involving caregivers in the process of preparing for lung transplant. They described a need for providers to time conversations about transplant appropriately and to be forthcoming with information. And then common information needs were identified across the interviews. Things like housing, finances, social support, the evaluation process, which tests will be done and which tests are most difficult, surgery, the actual procedure, and then subsequent recovery and how long and how difficult the recovery is. And then even though chronologically it's last, life post-transplant was the most common response to what are the information needs that somebody considering transplant really has to address. And understanding the success and survival and quality of life related to a lung transplant was really important. And one person didn't like the idea of calling it survival after transplant. He said that we should call it surviving and thriving after lung transplant, so that people can get excited about the opportunities and the promise. So we decided, based on these interviews with the post-transplant patients, as well as some survey data from our non-transplanted CF patients and our work on the CF lung transplant referral guidelines, that a decision support tool could be really helpful here. And so we developed a web-based educational resource for pre-transplant CF patients that incorporates up-to-date CF-specific information with the goal of helping people with CF learn about lung transplant, gain exposure to lung transplant recipient stories, and facilitate conversations with their CF doctor. So we created CF stories, and from the interviews with the CF lung transplant recipients, we created CF stories in partnership with patients and caregivers, and we developed a collection of personal narratives about the CF lung transplant journey. We edited all of the stories for medical accuracy, but they're all told in the patient or caregiver's words. 12 out of the 20 participants from the study created CF stories, and then we expanded to non-UW sites, and we used people from the CF Foundation's community voice to create more stories. And now we have 28 CF stories that are available with varied outcomes. And so some of the patients in the stories went through lung transplant and they described that journey. Some of the stories are from people who started on Trikafta and they got better and they decided not to go forward with transplant at that time. We have caregiver stories from lung transplant recipients, and we also have caregiver stories from people who died post-transplant, because obviously people who die can't tell their story anymore. And so we tested the preliminary efficacy of the CF stories. We enrolled 25 CF patients across 4 sites: the University of Washington, University of Minnesota, National Jewish Health, and University of Pittsburgh, and from the CFF Community Voice. And 25 out of 31, or 81% of people that we approached, agreed and participated. Their average FEV1 was 47% of predicted. We did a 90-minute Zoom intervention where participants had access to 7 CF stories, and they read an average of 3 of those stories. And we measured their decisional conflict scale, Likert scale of preparedness for transplant discussions, and their knowledge about lung transplant before and after just 90 minutes with 3 stories. And we saw significant improvements in all of those measures. Participants gave feedback on the tool and they loved reading the stories, but they wanted more medical information and more facts as well. And so we put together a decision support tool that has the CF stories as well as a resource library and frequently asked questions about lung transplant. And we're pilot testing that now. We started enrollment in July of 2021, and we're enrolling people who have an FEV1 less than 50% of predicted. And we're giving them 2 weeks of unlimited access to the tool, the CF Stories, Resource Library, and frequently asked questions. And we're measuring changes in their preparedness for lung transplant discussions, their decisional conflict, and their lung transplant knowledge. And we're planning to enroll 60 people, and it's supported by the CF Foundation K-Boost and an NIH R03. And we've enrolled 9 people so far, and the results have been very promising. And the one thing that was interesting is that people spent a lot of time with the tool in just 2 weeks. The average amount of time for our first 9 people was over 4 hours. So our next step is to do a randomized clinical trial, and we're hoping for enrollment to start in 2022. We'll again enroll people with an FEV1 less than 50% of predicted, and this time we'll give them 3 months of unlimited access to the tool or an attention control. And we're going to measure changes in preparedness for lung transplant discussions, decisional conflict, and lung transplant knowledge, and whether the tool influences their discussions about transplant with their CF provider. And we're hoping to enroll 125 people across 8 sites in the United States. So in summary, CF lung transplant recipients reported that connections with transplant recipients help them to prepare prior to transplant. They also identified information needs, learning what to expect from the evaluation process, knowing the risks of surgery, and understanding life post-transplant. CF patients, both pre and post-transplant, wanted a lung transplant resource that contained CF stories or personal narratives and objective medical information. And they really liked the idea of having everything in one place. And the rationale for our ongoing research is that CF-specific lung transplant education can provide the clinical, social, and emotional context for lung transplant decisions and increase patients' preparedness for discussions about lung transplant. Thank you so much for listening to my talk, and I look forward to seeing you at next year's NACFC.
Okay, so that was Dr. Ramos, and as you can see, she's one of the busiest people ever. I encourage you guys to go see all of her sessions this conference, but she has a colleague, Lauren Bartlett, who is joining us to answer questions. So I will go ahead and kick it off while my friend Bob handles the Slido. Please put your questions in. Your selection process, you had 86 patients, but you guys approached a portion. Can you go into, your thought process on who you approached initially for the pilot?
Yeah, sure. So we had a kind of a pool of patients that we started off with, and we selected patients based on a number of characteristics to kind of get a generalizable amount of experiences based on gender, how far out they were from transplant. We selected patients who were less than 5 years out from transplant, just because they were more likely to remember the process as opposed to someone who's a little bit further out. And then we also included some patients, depending on their insurance status. We wanted to kind of bring some perspectives that may have influenced that going through that transplant process, and like Medicare and Medicaid insurance was in that decision making. And then, generally people were interested in kind of sharing their experiences. And we had told them that we understand that this process could definitely be improved, and we kind of need your help to help us understand what needs to be changed, what needs to be fixed. And people were very willing to share their experiences with us.
Yeah. And do you think that there was some interview bias by hitting them post-transplant? I think hindsight is 20/20 a little bit. as opposed to interviewing, pre-transplant or in the process of the journey.
Yeah, absolutely. We chose to interview post-transplant patients because we thought of them as experts. They've been through the process. They know the ins and outs, whereas pre-transplant patients they don't know what they don't know. And so we were surprised, even talking to some post-transplant patients, how much they didn't know when they were going through that process, and they recognized, oh, I didn't understand this at the time. I wish I knew about this kind of stuff ahead of time. And so that's kind of where we discovered these things, that there were still information needs for people going through the transplant process.
Okay. I have a question from one of our co-speakers saying, I have some, it just cut off on me, apologize. I have some patients that have severe anxiety about lung transplant and feel that it means they are at their end of their life, which I think we've all heard this. Did anyone of the post-transplant patients feel that they made the wrong choice?
Yeah, that's a great question. To my knowledge, the people that we spoke to, they did not express that explicitly. Most of the people who I think we talked to had mostly good things to say. There is a lot of anxiety involved in going through the process, and that's one of the things that we are measuring throughout our future research, is how our tool can potentially alleviate some of that anxiety, whether it's due to lack of information or the right information. That's definitely something we're looking at.
And then this is a question from the audience. Are the web-based educational resources for pre-transplant CF available to access now? It sounds like people want to use your stuff.
Yeah, we wish. We're working on it. We have a lot of testing to do before it is available, but that is our goal, that it will be widely available for everyone to use.
Maybe this would be a good time to plug that you will be enrolling in the next phase of your trial.
Exactly.
And then for your future larger study, will you be using a mix of larger and smaller centers, rural versus urban, as resources and needs may differ? Yes, that is one of our biggest priorities. We want to get kind of perspectives from everyone across the spectrum who may have more or less exposure to transplant, and to kind of help us make our tool better, than cater to those different populations. Okay, and then last question. Oh, we have two more. I apologize. How are you going to engage in caregivers in this? Is there any thoughts on engaging with our caregivers? Yeah. So caregivers are another really big piece of the puzzle. They are going through the transplant process with patients. And so they have to kind of also prepare for being a caregiver of someone going through transplant. And so we have content available in our tool that is specific to caregivers. And then we also have stories that are provided by caregivers, where they kind of offer their view on going through transplant. Okay. And then this will be the last question. And again, any questions, please reach out to either Lauren or Dr. Ramos, because this is a fantastic talk. Does your lung transplant program have educational seminars, and is this being used as a supplement, or is this being used in lieu of that? Yeah, so our center does have an educational workshop where patients can go to kind of understand transplant. The information that is provided is very in depth, and
the material in our tool is kind of a supplement to that. And so at our center, people are required to take that educational class before they get listed for transplant. But we have experienced patients who say they still have questions after going through those types of classes. And our stories are one of the things that they're kind of looking to get kind of a personal experience that's just not covered in those types of classes.
Absolutely. Those stories, there's never enough stories to listen to when it comes to these types of cases. So thank you so much, Lauren, for filling in for Dr. Ramos. I appreciate the dialogue. And then we will go ahead and move on to our next speaker. Dr. Midhour Oxler has an almost 20-year work history that ranges from research scientist, inpatient pediatric CF nurse, to pediatric nurse practitioner. Her research interests include transition to adult care, communication in healthcare, and palliative care. She currently holds the role of the CF Transition Coordinator and nurse practitioner for the Emory and Children's CF team. She is currently a champion advocate on the National Cystic Fibrosis Foundation Committee, Partnerships for Sustaining Daily Care, whose purpose is to address the issue and burden of adherence to CF daily treatment. She is also a trainer for the Partnership Enhancing Program, PEP, for the Cystic Fibrosis Foundation.
Hello, I'm Brandy Midhour Oxler, and thank you for coming to the presentation today. I'll be presenting on improving assessment for CF pediatric palliative care, initial development of the ADAPT CF communication guide with children and caregivers. Here is my disclosure. And today I plan to discuss the background, really the reason why we developed the ADAPT CF communication guide. Then I'll discuss the development process itself and possible implications for the future. The work was undertaken as part of a larger multi-site primary palliative care implementation trial. The co-PIs of that project, known as Improving Life with CF, a primary palliative care partnership, are Dr. Anna Georgiopoulos and Dr. Lara Dingra. They're pictured here on this slide. I just wanted to acknowledge their larger work before discussing this much smaller piece. So earlier this year, the evidence-informed consensus guidelines for palliative care delivery for individuals with cystic fibrosis were published. On your screen, you'll see one of the many recommendations within the guideline. This is recommendation number 10, which addresses screening and the assessment of palliative care in pediatrics. Here, the recommendation was made that we should use the IPOS to guide conversations with children under the age of 12 who have CF and their caregivers. This should be done annually and at disease milestones to identify unmet palliative care needs. So in this project, we set forth to design a conversation guide to systematically meet this recommendation. Here I want to talk a little bit about what the IPOS is. The full name is the Integrated Palliative Care Outcome Scale, or IPOS again for short. It's been validated for people 12 and over. It's a comprehensive and robust instrument that measures the most commonly reported concerns for patients in palliative care. It measures physical and emotional symptoms, but it also measures information needs and practical issues that may be missed by other scales. It is a brief instrument, brief enough to be used in routine care, and it's found to be responsive to change. The IPOS is comprised of 17 topics plus an open-ended question. 10 questions investigate physical symptoms. The specifics of those are listed here in the green box. 4 items inquire about emotional symptoms, listed here in the dark orange. 2 questions ask about communication needs, shown here in blue. And then also practical issues, shown here in purple. In addition, an open-ended question asks about the main problems or concerns the patient may have had which may also be considered a practical issue as well. So for this project, our aim was to fulfill, again, those palliative care, what the guidelines were asking, to use the IPOS as a guide for conversations, to investigate distressing symptoms and palliative care needs for people under 12 with CF. In addition, it needs to reflect common symptoms, stressors, and the specific needs of people with CF in this age range. The age group needing to be addressed spans from birth to 11 years old. These groups have distinct developmental needs, including attention span and language. So we chose to break the age groups down into 3, which are shown here. Questions were written to be open-ended to best elicit the child and the family's experience. For the 0 to 3 age group, questions would need to be directed to the parent or guardian. But starting at the 4 to 6-year-old age group, our intention is to direct the questions to the child first, and then open the question to the caregiver to clarify and fill in information as needed, knowing we would likely need to rely on the experience of the child and the caregiver to fully understand what the child was experiencing. For some children, this may be one of their first times answering questions in clinic and will help develop a skill that will serve them well into adulthood. The 7 to 11-year-old questions are intended to be asked similarly, child first, and then opened up to the caregiver for input. This will help embed relationship-centered open communication techniques in our care centers for all people with CF starting from infancy. It will also help stress the importance of not only physical symptoms, but also emotional symptoms and whatever is impacting the family too. So on this figure, I want to show how we developed the communication guide. The first step was 2 CF clinicians, myself and Dr. Rachel Linneman, using our knowledge in CF and the IPOS. We drafted age-appropriate questions to really look at the most common problems experienced by people with CF in the age groups that I identified on the previous slide. Our goal was to use plain language that would be linguistically and developmentally appropriate for those groups. After questions were developed, we received feedback from Shayna Blair, our mental health coordinator, and 2 pediatric CF social workers, and further revised the questions. After that, we presented them to our Family Advisory Council, which is a racially and ethnically diverse group of parents, all who have children in the age range that we're looking at here. We weren't sure really what the parents would think, but the response was overwhelmingly positive. Several of the parents really wanted to know how their kids would answer these questions, and many said they didn't quite know how to ask these questions themselves. And we're very thankful that we were going to be incorporating this into our assessments in our center in the future. Then the guide was presented to the larger group of CF and palliative care experts and stakeholders, which includes someone living with CF. And it was again revised, which resulted in the final communication guide. So here you'll see that I've named it Assessing for Distressing Symptoms and Palliative Care Needs Through Targeted Communication, or ADAPT CF Communication Guide for short. So currently the ADAPT guide has 26 questions in its current form, 4 questions for the 0 to 3-year-old age group, 8 questions for the 4 to 6-year-old age group, and 14 questions for the 7 to 11-year-old age group. So here I just wanted to share some of the questions. Actually, these are all of the questions from the 0 to 3 age group. Again, these will be parent or guardian directed. On the left, you can see the original IPOS domain that the questions were drawn from, and on the right, the questions themselves. Something to note is question number 3, which asks how the child is coping with labs, shots, and procedures. So this was something, procedures and procedural anxiety, that was not reflected in the original IPOS. But we know that it's something that can greatly impact children with CF, and we felt that it should be addressed in the guide. So you'll see that here there's also a probe question to help learn more about that question. So for this question, the probe asks, how could lab draws, blood draws, or procedures, how they could be approached better to help the child cope? So we hope that this has the potential to improve patient care, to increase partnering, and address procedural anxiety for even the youngest people with CF. So here are a couple questions from the 4 to 6-year-old age group. This age group has a total of 8 questions since their attention span is a bit longer. And to stay within the time frame, I'm just touching on these briefly. But these questions, again, would be child-directed first. Here you'll see the first question is rapport building, asking the child what they do for fun, what they enjoy. But this helps practically a bit later in question 3, when the interviewer will refer back to that activity to make sure that the child feels good enough to do that activity that they named. So this really looks at the physical symptoms that the child might be having, whether it would be pain preventing that activity, lack of energy, or maybe a practical matter as well. So here are a couple of questions for the 7 to 11-year-old age group. This could help improve knowledge and communication for our young people with CF, I think. These 2 questions are open-ended and create an opening for them to ask any questions that they've been pondering. So 13, it's your question. It's your turn to ask a question. What question would you like to ask me about cystic fibrosis? Or what question do you have about your medicines or your treatments? I actually asked these questions in clinic just recently and was a little surprised that the first question that the young person had for me was about lung transplant. What is lung transplant? Why do people need them? And it was a bit unexpected for me, but it was exactly what was on this child's mind. And these were questions that evidently he'd been afraid to ask before, but a powerful example of how these open-ended questions can reveal what even young people with CF are wondering. So currently, the 26-item version of the ADAPT CF Guide for Children and Caregivers is undergoing a modified Delphi approach involving CF experts, where revisions will likely occur. And after that, it will be pilot tested at our pediatric sites with 10 to 12 patients and families of different ages using them, and it's going to be followed by cognitive debriefing. The final version will be field tested in our palliative care study sites to determine its usefulness. So the ADAPT CF Communication Guide has the potential to increase the acceptability and effectiveness of palliative care screening for people under 12 with CF. It could identify young children and families at risk for illness burden and improve standardization across providers and programs. It has the potential to help identify needs that are specific to people with CF and their families as well. And I do want to mention that the larger palliative care grant, Improving Life with CF, will be providing the community a plethora of CF-specific palliative care resources. This includes handouts, webinars, and trainings. Many of the trainings have excellent case studies. Here is just an example of a slide from one GI-specific education done by Dr. Georgiopoulos. She's embedded the questions from the ADAPT CF into the case study itself, which are represented in bold here. These are looking at physical symptoms related to GI distress. It's looking at appetite and questions the patient has about the medications that they're taking. So if you'd like to learn more, you can go to the website that I've listed here. It may not be live quite yet. If not, just check back soon as these resources will be available widely. And special thanks to the collaborators who've made the development of the ADAPT CF Communication Guide possible. And those are my references. So thank you and have a great day.
Wow. I am in awe. We'll have to talk after this, okay?
Absolutely.
So let's get this going. While please, again, everyone put your questions into Slido and Bob will feed those back to me. Please take this opportunity to hear from a developer. I mean, this is really great. I have to ask, how long is it taking for you to administer this questionnaire, especially with the littles?
Yeah, we're finding some variance in it, and we're really just starting to pilot that. So I think there's going to be some times where we go through with, especially the 0 to 3 age group, where you ask the 4 questions, and it may take 5 or 6 minutes because there's nothing to uncover. But I think a lot of times, especially if it's something that someone's been holding in for a long time, that there's a lot of emotion and there's a lot of feelings there, and it may take a little bit longer. So it may take, 15 or 20 minutes. But one of the great things that we're doing as we develop this and pilot it is time it with our age groups, just to see the age range and what we're expecting.
Okay, we have a question that someone wants the website name. So again, I believe it is improvinglifewithcf.org.
Yes.
Everyone write that down, improvinglifewithcf.org. Plugging the website.
Yeah, and I do want to say that the resources, the patient-facing ones, I believe are up right now. So there's going to be provider training, and there's also going to be CF-specific patient resources that will be available in Spanish as well as English. So I think that will be just a nice addition as well.
Great. Now, this is a question from one of the speakers. How did the families respond? So you presented it to the family council. How did they respond to the use of the word palliative in the name? Because there's a lot of connotation with that.
Yeah. And, I think in the beginning, we were actually more worried about it. I know my center director, Dr. Linneman, who's on the grant with me, we were kind of scared to even mention those things to them. And when we really put it under the umbrella of palliative care, also talking about distressing symptoms, what can be impacting their quality of life, they kind of looked at us and said, no big deal. Like, of course, there are things that impact our life. And they were just so thankful that we wanted to address it and not sweep it under the rug. I didn't say it in my slide, but my best friend, son has CF as well. And so I tend to run these things by her as well. He's a teenager. And she was thrilled. She's like, yes, anything that is impacting his life that you can impact, ask it. So it's interesting that we had more worry about the palliative care terminology than actually it seemed like the patients did.
I think that's an overall theme with a lot of stuff is sometimes we just need to talk to our patients because who knows best, the patient. Another question. So in your idealized world, we're through all of our piloting. We've tested this. How do you anticipate this tool being used in day-to-day practice?
Yeah, great question. And I think it may vary for different sites, but at our site, we imagine it being used at the minimum at least once for an annual screening. And then we think that we're going to devise triggered screenings. And when I talked about this with our Family Advisory Council, they really urged us that we were talking about if you were diagnosed with CFRD or maybe a new microorganism that's growing in your lungs. And one of the moms said, it is not when my child's diagnosed with CFRD, you mention that it's a possibility, and that's when it weighs on me. So they really said, please, when you're thinking about this and the implementation, don't make it a hard diagnostic line. Really try to think of it as when the topic is introduced. If something is up in the air, and especially if it's not black and white, that people really struggle with that as well. So I think that is going to really change how we look at where we might implement this in the future.
Yeah, I think that's a really great idea. I didn't even think about that. Using it in triggering times, not just every March.
Yeah, exactly.
Yeah, and so when you are going back to your patient advisory committee, how often are you checking in with them just to get their feedback?
Yeah, we check in pretty often. So once we start piloting this, we'll check in with them again because several of them will be some of the people that we'll pilot it with. We're going to get the feedback both from our providers in clinic and also from the Family Advisory Council again. And then we've got that large palliative care multi-center site that includes people with CF. And so we'll get feedback from them as well. So it'll really be multi-layered on the different type of feedback that we get.
And then how do you anticipate this being moved? Because obviously right now, a lot of us kind of huddle pre-clinic, a few days ahead of clinic, and this is going to potentially have some real live things like your example of the little talking about lung transplant, which just absolutely blows my mind. Do you think this is going to change the way your clinic runs?
We think it may. So we're thinking of doing it really one of the first things after they get into clinic. That way, if something is triggered and we find something from those questions, that we can really address it instead of finding out about it after clinic or at the tail end, because it really could change the entire way that your clinic flows. I mean, if a parent came in and they were worried about blood draws that day and they haven't slept the night before, but they haven't told us about it, and they're getting blood draws, I mean, we kind of need to quickly huddle and come up with a plan that addresses what they're feeling that day. So I think it'll need to be at the beginning of our clinic encounters. We're trying to really think about how we do that, whether it's our social worker or whether it's the provider that does it. And we'll just have to see. We'll have to see how the pilot goes to really inform that as well.
Oh, man. You're teasing future things for us.
I am. I do want to mention, too, that Indiana University is coming out with some great courses that include communication and palliative care. Dr. Georgiopoulos has included the ADAPT CF in her course that will be coming out in the upcoming months. So you can check there for a little bit more about that as well.
Great. Well, I look forward to hearing what the next phase of this is. So please come back next year and tell us how it's going.
I promise.
Great. We will now transition to our next speaker again, please put your questions into Slido. So I am proud to introduce Hoang Yen Vo. Yenny is a clinical pharmacist at Memorial Care Long Beach Medical Center since 2016. She joined the adult CF clinic as their pharmacist in 2018 and has been with the team since. As a clinical pharmacist, she is able to fulfill her career goals of being a patient advocate and managing complicated CF therapies and collaborating with incredible colleagues in a multidisciplinary team. In 2020, she also joined the CF LTT LLC3 to collaborate with the UCLA lung transplant team to improve lung transplant transition processes in CF patients with advanced lung disease.
Hi, everybody. My name is Hoang Yen Vo, and I will be presenting today's presentation for this workshop. Our workshop is on the standardization of lung transplant discussion in adult cystic fibrosis patients, a CF Learning and Leadership Collaborative QI project. For this presentation, I have no relationship to disclose. So to give you a little bit of background on the collaboration, the project ran between July 2020 and September 2021. Our center's goals in joining the project were to improve quality of care and patient outcomes in the lung transplant transition process, and to collaborate with the Lung Transplant Center in improving shared care. Our center was the CF Referring Center, that is Memorial Care Long Beach Medical Center. Our partner in the project was the Lung Transplant Center of UCLA. This is the overview of cystic fibrosis lung transplantation divided into 8 phases. For our QI project, we focused primarily on phase 1, which is initiating the conversation. We first began the project by modeling our referral process into a flow chart. The clouds in the flow chart represent areas of inconsistency or variability. We decided to focus on the first cloud, which is identifying advanced lung disease patients to initiate lung transplantation discussion. Our global aim for the QI project is to improve standardization lung transplant referral at the Long Beach Memorial Care Cystic Fibrosis Center. The process begins with identifying advanced lung disease patients needing lung transplant and initiating lung transplant discussion. The process ends with the patient receiving lung transplant. By working on the process, we expect to improve quality of care and patient outcomes. For our first Pdsa cycle, the specific aim was to identify and initiate lung transplant discussions with 100% of ALD patients who comes to clinic by March 2021. The change idea for this cycle was to have a physician-led screening. So we will identify patients' ALD status based on FEV1 and color code that ALD status, with red being FEV1 less than 30%, blue being FEV1 between 30 and 50%, and green being FEV1 above 50%. The physicians will then send out a pre-clinic email 48 hours prior to clinic day. The physician will also initiate or continue lung transplant discussion on clinic day and document that discussion in EMR. The results from the first Pdsa cycle show that only 72% of patients were screened for ALD, and only 25% of those ALD patients had lung transplant discussions documented in EMR. For our second Pdsa cycle, we kept the same specific aim. The change idea, however, is changed to a nurse-led screening. So we kept the same parameters for ALD status. One of our nurses will screen patients for ALD and color code the patient's ALD status on a whiteboard located in the clinician's workroom morning of the clinic. The physician then will initiate or continue lung transplant discussion in clinic and documentation. The results from the second Pdsa cycle showed that 100% of patients were screened for ALD. This was improved from 72%, and 91.7% of ALD patients had lung transplant discussions documented. This was improved from 25%. These are the two charts to show our two Pdsa cycles. The top chart showed percentage of patients screened for ALD. You can see that our Pdsa cycle number 1 are labeled in represented by the blue bars. The cycle ran between December 2020 through January 2021. And as mentioned before, only 72% of the patients were screened. And you can see one of the weeks where screening was missed completely. For Pdsa cycle number 2, the bars are represented in red. And as you can see, 100% of patients were screened for ALD. The bottom chart show percentage of ALD patients who had lung transplant discussion documented. So same as before, Pdsa cycle number 1 are shown in blue. You can see several weeks there where lung transplantation discussion either did not occur or was not documented. And Pdsa cycle number 2 are also still shown in red. You can see a big improvement from Pdsa cycle number 1. For our third Pdsa cycle, we aimed to improve standardization by creating an EPIC smart phrase for lung transplant discussion and by April 1st of 2021, and we will continue to improve this template until June 2021. The change idea for this cycle was driven by the fact that a shared EPIC smart phrase will allow for standardization of the content of discussion, regardless of which provider saw the patient that day. This will also help to improve documentation in EMR. The result from Pdsa cycle number 3 was an EPIC smart phrase. This is the abridged version of that template. But as you can see, it included essential discussion points, such as whether or not the lung transplantation was discussed in clinic that day, when the last discussion was, the stage patient is in, what the discussion entailed, barriers to the discussion and how that was addressed, and social support for the patients, as well as the plan moving forward. For our Pdsa cycle number 4, we aimed to improve documentation of lung transplant discussions by utilizing the developed EPIC smart phrase in EMR from 0 to 100% by June 2021. The change idea for this Pdsa cycle was implementation of the shared EPIC smart phrase in clinic to standardize lung transplant discussion. The results from this Pdsa cycle showed that utilization of the EPIC smart phrase is at 100% since implementation. And during this time period, percentage of eligible ALD patients who had lung transplant discussion documented in EMR was increased from 91.7% from the previous Pdsa cycle, increased to 95% for this Pdsa cycle. This is a chart showing a combination of our 3 Pdsa cycles. The bars in blue represent the percentage of patients screened. You can see that has been consistent at 100% since February of 2021. The orange bars show the percentage of lung transplantation that was discussed. The gray bars show the percentage of the EPIC smart phrase template that was used, and that has been consistent at 100% since April 2021. For our 5th Pdsa cycle, we aimed to improve the CF team knowledge regarding lung transplant referral measured by the Johns Hopkins Self-Knowledge Assessment Survey. The change ideas were to improve lung transplant education for the CF team, and we did so by reviewing the CF Foundation lung transplant guidelines during team meetings. We collected pre and post education score survey scores to measure self-knowledge. So the results for this Pdsa cycle show that after 2 educational lectures, the average team score improved by 1.1. And this is a chart showing that improvement. As you can see, we did a pre-education survey on February 3rd of 2021. That was our baseline score. After that, on the same day, we did the CF Foundation, or we reviewed the CF Foundation lung transplant referral guidelines. A month later, we reviewed CF lung transplantation overall as an education, and you can see the gradual increase in the self-knowledge survey scores. So in conclusion, standardization of care in the lung transplant transition process improved identification of ALD patients, lung transplant discussions, EMR documentation, and staff knowledge. We also began incorporating a 6-minute walk test into our clinic workflow towards the end of the project. And that has really improved completion rate as well. Patient and families guided many of our Pdsa cycles and change ideas. Some limitation to the project was time and staff availabilities that were issues that came about due to COVID-19. This is a picture of our team members, as well as some of the UCLA team members, as well as our coach. We'd like to send a big thank you to Dr. Fadi Asfer, Deb Ward, Emma Kors, and Nathan Kors for guiding us in our collaboration. Thank you.
Wow, thank you, Yenny, for sharing this. I have to plug the LTT LLC programs. Loyola was involved in the original set, and so I'm seeing a lot of themes that came out with ours. So let's kick off with a question that I have. You mentioned this in your conclusion, but I kind of want to have you expand a little bit on how you incorporated the patient voice or their families' voices into your Pdsa cycles.
Yes, so we were very grateful to have a post-transplant patient and his mom who were on with us every Friday meeting, and that was how we got their input. So they were very involved, and we're very lucky to have them to take that time with us.
I think it's funny that your first Pdsa cycle, you know, I don't want to say failed miserably, but I think it was a great example of how you need to use the right people in the right role, 100%. And that the screening got much better when nurses did it, because, you know, we do the things. So how are you screening? Are you screening in a patient huddle, or is the nurse kind of doing this on their own time for your ALD patients?
So the nurses are doing this before clinic starts. So we have clinic every Wednesday. So Wednesday morning, all the patients who are being seen that day, their names are written on a whiteboard that we have in the provider's room. The nurses will then go through with the FEV1 or the last FEV1 value and then color coding them according to their FEV1. That will then flag the provider to either have a discussion or discussions not needed for the patients that day.
Okay. And then this is from one of the other speakers. They said, I find that either patients or providers sometimes try to avoid discussing transplant.
Yeah.
How many times per year are you talking to your ALD patients about transplant?
So I don't have an exact number, but I would probably think at least 4 times a year, because we do aim to see our patients quarterly. So for patients who the providers have had discussions in the past and patients had declined, of course, they're not going to be visiting it every quarter. But for patients who are interested with every quarterly visit, that is readdressed, and to see if they have any, because as I'm sure you are aware, patients will do their own research at home and then will come back with more questions, or something might change, one of the barriers might change, support system might have changed, their location might have changed. So that is addressed at every visit.
Have you found any of your patients who got this and changed their behaviors or changed their level of compliance because of this intervention?
I think one of our patients had, one of her barrier is her BMI. So she was quite overweight. She's lost a significant amount of weight since the first lung transplant discussion. That kind of coincides with other things going on in her life, but I definitely think it's motivation.
Yeah, and there was actually an endocrinology workshop earlier this morning that is showing that we now have obesity in our CF patients. Go figure. So I learned a lot about that today. So you described this kind of pre-clinic email that's being sent by the providers to the patient. Can you describe what's involved in that email?
Actually, it wasn't to the patient, it was to the clinic staff. That
Okay.
was the part of the first cycle. Yeah, it was to the clinic staff. It was sort of like our current whiteboard, except just in email form. So patient's name, their last FEV1 value, what was discussed at the last visit, and then their names are color-coded in either green, blue, or red, depending on their FEV1s. Yeah, and then that was sent out to the whole team.
Okay. And then, so this shows that sometimes using the more electronic high-tech stuff doesn't necessarily work, and you go back to the whiteboard with the dots on it. Got it. Okay.
Yes.
We found this too. Don't worry. We're in the same boat. And then The other question I had with this is, are you having only providers speak to patients about transplant, or are you really trying to have everybody from your team kind of buy into the conversation?
Yes. So in our clinic, primarily it is the physician who discusses with, so we actually talked about this when we were starting the project as to who should be the first to initiate the conversation. And I think the whole team felt that it was more appropriate for the physician to be starting that conversation. And then should that conversation lead into other questions regarding whether it's medications, then, I can step in, or whether it's about diets or change in meal plans, then our dietitian will certainly step in. But yes, our physicians are the ones to start the conversation.
Okay. So I am going to give you a little pushback on that. As the original CF lung transplant consortium group, we had a very similar approach, and we surveyed our patients and we said, who talked to you about transplant? And then the other question was, who did you want to talk to you about transplant? And it was very surprising that almost 50% of the patients did not want to talk about transplant with their physician. They wanted to talk about it with their nurse.
Oh.
So I think that this just shows again that, and I think this is a theme throughout all of these, is that we put a lot of our assumptions on our patients, when really we just need to ask our patients what they want. They will help us.
Yeah.
So I don't see anything else with questions. Let me just double check.
And sorry, Erin, I have a question for you then.
Yeah.
Do you work with primarily adult patients or pediatric?
I work with adult patients, but we do have the occasional pediatric come through our doors.
Okay.
But we are blessed to have St. Louis, which has an amazing pediatric lung transplant program right down the road from us. So we just send them on down there. Okay, well, thank you, Yenny, for this great example of how small, teeny tiny steps can lead to big changes in your practice. I really, really value this talk, and I think it's so important to do. So we are going to transition to our final speaker. Dr. Sellers is an assistant professor of pediatrics and associate chair of research in pediatric gastroenterology at Stanford University, where he also serves as the director of the Stanford Children's Pancreas Program. He is a member of the Digest, which is Developing Innovative Gastroenterology Specialty Training Program, and was a recipient of the CF Foundation's Leroy Matthews Physician Scientist Award. Dr. Sellers' clinical and research activities are centered around improving the gastrointestinal, pancreatic, and liver health of those with cystic fibrosis. His laboratory investigates new pharmacologic and gene editing approaches to correct ion transport defects in CF. He is also an active clinical researcher, serving as an investigator of Galaxy and Inspire 2, while investigating the utilization of non-invasive modalities to diagnose and monitor CF-associated liver disease.
Thank you to the workshop chairs for giving me an opportunity to present our abstract in this session. My name is Zachary Sellers. I'm a pediatric gastroenterologist and assistant professor of pediatrics in the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at Stanford University. Now we'll be presenting this abstract in lieu of Stephen Levitt, a pediatric gastroenterology fellow at Stanford, who could not be here to present the work himself. I invite you to see this work at poster number 212. I have no relationships to disclose that are related to this presentation. However, I do receive grant funding from the CF Foundation, the NIH, and NASPGHAN Foundation for research unrelated to this presentation. A variety of liver abnormalities may occur in CF patients. These are discussed in the clinical symposium, Updates in CF Liver Disease. Briefly, these may include elevated liver function tests, fibrosis, cirrhosis, steatosis, and/or portal hypertension. Cftr correctors and potentiators, also known as modulators, may improve sweat chloride, FEV1, and BMI to various degrees. However, what is still unclear is how these modulators may impact liver health. We and others have shown that specific labs and fibrosis indices can help identify early versus advanced liver disease. For example, GGT and GGT to platelet ratio perform well in identifying mild to moderate fibrosis, while platelets and the AST to platelet ratio index do well in identifying moderate to severe fibrosis or cirrhosis. In this prior publication, we identified lab thresholds that corresponded to different degrees of liver fibrosis based on ultrasound and/or MR elastography. In the table here, the black arrows highlight the performance of GGT and GPR in detecting early disease, whereas the red arrows show that platelets and APRI do best with more advanced disease. Through this prior research, we were able to develop a good understanding of the liver phenotype of our CF patients. With this in mind, we sought to evaluate whether lumacaftor ivacaftor, called Orkambi in the US, or tezacaftor ivacaftor, called Symdeko, had a positive or negative impact on the liver health of CF children and adolescents at our pediatric CF center. We performed an IRB-approved, single-center, retrospective analysis. We examined all of our patients and included anyone on one of these Cftr modulators for at least 6 months and had liver function tests available to us before and after starting the modulator. We excluded those patients who had a liver transplant, and we also excluded specific labs that, upon review, were deemed to be negatively influenced by drugs other than these Cftr modulators. These accounted for only a small percentage of the total labs, as you see here, at 3.8%. Using caliper normative data for age and sex, we calculated APRI and GPR pre and post Cftr modulating. There have been a number of different definitions that have been used to define CF liver disease in publications. For this study, we defined those with liver involvement as having one of the following: imaging showing nodular liver morphology, imaging identifying splenomegaly for age, an abnormal ultrasound shear wave elastography or MR elastography study, an APRI greater than or equal to 0.345, or a GPR greater than or equal to 0.403. These elastography, APRI, and GPR cutoffs were determined based on our prior research indicated here. From approximately 230 patients, we identified 50 that met criteria for analysis. We had 38 without liver involvement and 12 with liver involvement. The majority of patients were treated with lumacaftor ivacaftor. Both groups were on Cftr modulators for an average of around 3 years. There were no differences between any of the groups, with the exception that more of the liver group were on ursodeoxycholic acid. We first examined what proportion of liver function tests were abnormal before and after Cftr modulators. For these graphs, the y-axis shows the percent normal for any given lab, with the dotted line indicating the upper limit of normal at 100%. On the x-axis, each line of dots represents an individual patient, and in these graphs, we're showing all patients, both those with and without liver involvement. Black dots are those values pre-modulator, and gray dots are post-modulator. The plus signs indicate labs that were excluded. We found that there was generally a similar percentage of abnormal labs both pre and post Cftr modulator. In order to ensure no specific patients skewed the results, we then looked at the proportion of patients with abnormal labs. There were less patients with abnormal AST, ALT, or GGT after being on a CFTR modulator, although the decreases were all less than 10%. We then examined the temporal changes in labs and fibrosis indices, APRI and GPR, in those with liver involvement. Here, the x-axis shows the amount of time before and after starting the CFTR modulator. We calculated regression lines and slopes as indicated by the lines and numbers at the ends of them. We saw that there was no change in trends before or after AST, ALT, or GGT. However, we did see a significant change with platelets. Before CFTR modulators, platelets in the liver involvement group were downtrending. Then upon initiation of the CFTR modulator, platelet values stabilized and stopped falling. APRI and GPR had significant P equals 0.05. Since this analysis included a variable number of labs for each patient, we performed a dual time point analysis using the lab values closest to the time of starting the CFTR modulator, and then used the lab value representing the longest time on the modulator. Each dot represents a single patient with lines connecting the pre and post values for that patient. The red line is the average trend across all CF patients. We found that there was a significant decrease in ALT, GGT, and GPR in those with liver involvement that were treated with lumacaftor-ivacaftor and or tezacaftor-ivacaftor. It was initially curious as to why no changes in platelets occurred. However, since platelet values stopped decreasing, then this made sense. There were no significant differences in any of the labs or indices in those without any liver involvement. Since this analysis included patients that could have been on either one of the CFTR modulators, we did a sub-analysis of those only on lumacaftor-ivacaftor, since that was our biggest group of patients. This analysis revealed similar results with decreased GGT and GPR post-CFTR modulator. But now, APRI post-CFTR modulator also became significant compared to its values pre-modulator. Similarly, those without liver involvement showed no change. In summary, we found that treatment with lumacaftor-ivacaftor or tezacaftor-ivacaftor improves specific non-invasive serum biomarkers of liver involvement, specifically GGT, APRI, and GPR. A recent analysis by another research group found similar results. They examined 28 patients, 23 with liver involvement and 5 without. They found that AST, ALT, GGT, and bilirubin all improved over time on lumacaftor-ivacaftor therapy. Thus, this data by our group and Drummond et al. Gives us insight that CFTR modulators may benefit CF patients with liver involvement, even independent of whether or not patients have existing lung disease. Thank you for your time.
Thank you, Dr. Sellers. Just finishing my question thoughts here. So again, everyone, please put questions for Dr. Sellers into Slido so we can keep this conversation rolling. I think it's interesting that even though we tried to make this a non-lung centric conversation regarding CFTR modulators and advanced disease, it wound up becoming lung centric. So I really appreciate Dr. Sellers being here. I know that in the one of the on-demand sessions, they looked at the CFTR modulator era and its impact on OPTN data for lung transplant. And I'm just wondering, from your experience, are you seeing a decline in the need for liver transplant or pancreas transplant with this in this era?
Yeah, it's an interesting question. First off, I'd say it's going to be too early to tell because liver cirrhosis is a long process that occur. And while a significant number of children may develop liver cirrhosis, most retain liver function even into adulthood. And in fact, it's a very relatively small number of individuals with CF that need to go on to liver transplant. So, and then even fewer individuals have pancreas transplants. So I think the numbers are small to begin with relatively, and then we sort of need more time to really see if we can make a significant impact in the rates of multilobular cirrhosis.
Great. I hope that you guys have the same effects that we have with our lungs, where we don't have to transplant these patients anymore. So you obviously included liver transplant in this analysis, but anecdotally, are you having your liver transplant patients on modulator, and how are they doing?
Yeah, it's a good question. It's one I get from colleagues at other centers as well. And I think that generally patients do well. There are, different considerations that we have to think of, similar to lung transplants. Immunosuppressive drugs can cause issues, and there are increased sort of a new set of problems that we need to think about. But in general, these medications are showing to be pretty safe. Again, the number of individuals with liver transplants on highly effective modulator therapies is going to be fairly small. But I think the question does come up too, if someone's had a lung transplant or no lung disease, but they have liver involvement, should they be placed on highly effective modulator therapy? And
what's your answer?
My answer is generally yes. I think that if they have, it's an interesting question if there's no other sort of symptomatic issues in other organs. But, I think if there is any sort of symptoms or disease in other organs, then we should be treating, the Cftr defects globally. We all know that CF is not purely a lung disease. In fact, causes a lot of morbidity with other organs. And so we should be treating those effectively as well as we can.
Agree. This is from one of our co-speakers. They said they watched your SO3 session, so thanks for plugging that. All of these are on demand, by the way, so go back and look at these. It appears that modulators may be liver protective. What are your thoughts?
Yeah, I would say it's a good question. This is why we kind of looked at, our data, and I know others are doing the same, as you could see from the reference from the Drummond et al. Paper. Again, data still seems to be accumulating. I think obviously in the US, we have a longer sort of experience with this than many other countries. Cftr has been around for a long time, but many of those patients that were qualified that didn't have significant liver disease was very low. And so we're really talking since the Orkambi era, and then more recently with Trikafta. And so, our data, we have some data that we presented at this year's liver meeting, the AASLD meeting, looking at Trikafta, which was interesting in that it may be that if you are on a prior modulator like Orkambi, you may not see big benefits for the liver. At least, even though Trikafta is much more effective modulator for, sweat chloride, and in some individuals, FEV1s. So your prior exposure to a modulator may, dictate how much benefit you get on this. The caveat to that data is, they showed here, we had individuals that were on average on modulator therapy for almost 3 years. whereas our Trikafta data, they're on average about 8 or 9 months. And so it may also be a time effect as well.
Yeah,
but I have seen anecdotally some of our patients do see improvement in liver fibrosis.
That's great. One question from the audience. What is the typical trajectory of platelets in patients with liver abnormalities who are not on modulators?
It's a great question. In very mild liver fibrosis, there doesn't seem to be any change, but as that liver fibrosis increases and the stiffness of the liver increases, that causes an increase in portal pressures, which then impacts the spleen, and you get a larger spleen, and that kind of chews up the platelets, so your platelets will go down. Without modulators, what we see is that over time, with worsening liver fibrosis and cirrhosis, those platelets will trend down. But it's important to note that while we, in non-CF individuals, we think of a normal platelets being above 150 and really don't get concerned, unless they're, below 100 or so. CF patients may have thrombocytosis and have elevated platelets. And so we found, and others have also found, that you can have significant liver involvement with platelets in the 220s or 230s. And so the message I give to everyone is that it's not necessarily just about the absolute value of the platelets, but if there's a continuous or downward trajectory over time, that's a cause for concern and needs to be evaluated.
Yeah, more of an individualized approach rather than looking at just reference ranges.
If you go from 400s to 300s to 200s, it's different.
Yeah, agree. And then, here's a statement from the audience. Thank you for this informative discussion. This reinforces my decision to continue Cftr modulator in my adult CF patient with cirrhosis while monitoring her hepatic function panel and platelet count. How, any advice for this provider in this new era and epiphany?
Yeah, there was a case discussed in Physician Grand Rounds about a patient that had cirrhosis, put on Trikafta, and needed a liver transplant, had acute decompensation for that. And so during our symposium earlier today, we had a long discussion about that. I think the collective thought from those of us in this area is that, if someone has existing multilobular cirrhosis, then it's the modulators, especially Trikafta, may likely to continue to be safe, but you may need a little bit more diligent monitoring of that. Now, if they have impaired liver function, certainly you need to be, I think, very aggressive in monitoring them to make sure that they don't acutely decompensate with that. But most have intact liver synthetic function. And I think that most of these individuals will do fine. But we just need to make sure that you've got a team of people that are thinking about these patients and monitoring them to make sure that they do okay.
So definitely have your hepatology team involved.
Yeah, I think we're getting, we always, I'm sort of biased, obviously, as a gastroenterologist, that GI and hepatology be involved in these discussions, but I think it's become even more complex. And, even before modulators, there are other reasons beyond CF where people can have liver abnormalities. We know that liver function tests can fluctuate over time based on different things. And now with modulators, that picture can be even more complex. So, I really encourage everyone to engage with local gastroenterologists or hepatologists, especially, if there's one familiar with CF and the nuances of CF. If there's not one locally, then, find someone that may be relatively close. And I know that, as Digest members are, sort of sprinkled all throughout the country, and always happy to, help provide, whatever advice we can without actually, seeing the patients and having all of the information.
And I think conversations, when we're getting into these really complicated patients, it is sometimes worth the 3 or 4 hour drive to get to the right person, to have the right discussion and make sure we're doing what's best for our patient, for sure.
Yeah, I mean, it's, typical for us and, other centers like us, right, to have people that come from a pretty broad geographical area. And, I will say that the, increased uptake of telehealth, it's become even easier, for new patients, especially when we want to do a physical exam. We like to see them in person. But after that, we do have a lot more latitude to do, to have labs or imaging done locally, and to have conversations via telehealth to continue to engage and provide that highly specialized support to areas that may not have that locally.
Yeah. Well, let's go ahead and bring on all of our presenters if we can. And let's just have kind of a brief discussion. And again, Bob is manning the Slido if anybody has any questions. Or
I think that the comment of, I'm going to try this on my patient is just as good as a question, because it's going to hopefully change practice, which all of these abstracts, the goal is to change practice. We had a pretty robust conversation in our chat. Do any of the speakers have any follow-up questions for each other? No one? And Bob, is there anything else on the Slido?
There is nothing left on Slido. No other
Okay.
questions.
And so maybe we can just close it out by having each speaker kind of give a one statement takeaway on how they're going to move forward with our extremely diverse set of topics. Let's start with the first speaker. Putting you on the spot.
Hi, it's Katie. So it's actually interesting because we're actually working on the Palliative Improving Life with CF project as well. So I think really collaborating with my team for palliative care and lung transplant initiative and just caring for our patients together. So that's my takeaway.
Agree. Who is next? Oh, I feel like a teacher. I'm calling on my students. Lauren.
Yeah, this is really great to hear all of you guys and all the work that you are doing at your centers. It's really fascinating, and we can learn so much from our patients and really listening to them and their experiences. Erin, I thought it was really interesting when you said that patients want to talk about transplant with their nurses and not specifically their physicians, and that's not really something that has come up in our research and might be something that we could potentially explore. So yeah, good food for thought.
Ooh, I'm glad I inspired something. Dr. Midhour-Oxler, any last minute takeaways from you?
Yeah, I'm actually going to add something to what you two were talking about, that when we did a survey of who they want to talk to about lung transplant adults in our CF center recently, about 20% of people said whoever they're closest to on their CF team. So they acknowledge that even if that was, if that was our registered dietitian, maybe that wouldn't make sense, but maybe that was the place they wanted to start. So I don't know, maybe think of that. But I think it all goes back to what I'm hearing as the theme for many of us is just to really always take it back to the experts and to remember that that's people with CF and their families. To really have a lot of open-ended questions about what they want and how we should approach things. And then to just keep moving forward on our initiatives and bringing them to conference so we can learn from each other too.
Absolutely. Yenny, any last minute thoughts from you?
Yeah. Thank you, everyone, for sharing all of your research. It is amazing to see what's out there. We're a very small center, so it's great to learn from other bigger centers and what you're doing. And Laura and Dr. Ramos, whenever that web resource is available, please share it.
Agree. And then finally, Dr. Sellers, any last minute thoughts from your end?
Yeah, I would say from this session, there was a lot of discussion about different modalities for communication and engaging with our patients for, centered around lung transplant. But as you mentioned, Aaron, like these concepts are not unique to lung transplant, right? But we see that in liver transplant or really any other major things, actually that we may be discussing with parents. And I remember when I first started diagnosing and educating people with, liver disease, they said, "What? I can get liver, problems?" It was like the new thing, and so it really sort of rocked their world a little bit. And we had so I think that a lot of the work you guys are all doing here and others is really applicable to other facets of diagnoses and management for our CF patients, and we should really think about these things broadly.
Yeah, I think that I would love to just live in a CF bubble and take care of CF patients all day, every day. But that's not the reality of probably any of our practices, where we are seeing lots of different people with lots of different diseases. And I think that taking concepts from the CF Foundation, who has amazing resources, and being able to apply it to other lung diseases, other GI disease, all of this is applicable if you look at it at a really high level and then alternately in the nitty-gritty details. So I think that's a really good point. I hope that this session has inspired the audience to take a question and run with it. As you can see, we had nurses, pharmacists, social workers, nurse practitioners, clinical research people. Research does not exist just in the physician realm. And so I really encourage everybody to, tackle a problem and see if you can come up with a solution. And just like Yenny said, if plan A doesn't work, go to plan B, C, D, E, F, G. So again, everyone is available for questions. You can send emails directly to our speakers, myself and Bob, or you can also send it to everybody on the NACFC chat session. I hope everyone has a good rest of their conference, and I will hopefully see you live in person in 2022. Everyone take care. Thank you so much.